Hi, everyone, and welcome to your pharmacology lecture series. Today, we're going to be focusing on antidepressant medications. Now, for the purposes of just giving you a bit of a disclaimer, like how important this is for your exams, I would say that antidepressant medications are very, very, very important to understand in conjunction with other parts of, the neurological system pharmacology, like anti-seizures and that kind of thing. And the reason why is because antidepressant medications are not just, I don't want you to think about antidepressant medications as being only used for depression. While that's the main function of these, there are so many off-label functions that are really only going to be known once you start doing clinical practice. Even I'm not sure what sort of the limits of these particular medications are, but they're so widely used that it's really good to have an understanding of why they're used and for what purpose they're being used for. Now, as always, I've linked my notes in the chat, in the comments underneath this video. I will say that in my notes, I've got general notes from the lecture, but I've also got specific notes under a pharmacology specific page that goes through each medication in a lot more detail in terms of mode of action, side effects, the pharmacokinetics and stuff like that, adverse effects, contraindications, as well as mnemonics to be able to really help you remember these. So if you're interested in that, feel free to check it out. But without any further ado, let's begin. So, firstly, in order to understand why we use antidepressant medications, it's a very good idea to know what clinically diagnosed depression actually means. Now, the most severe form of clinical depression is known as major depressive disorder, and it's often associated with overactivity within the limbic system, the emotion system that includes the amygdala. Now, on the right-hand side, I've got a couple of risk factors that are important to know for your history taking and clinical reasoning. But I guess for this one, it's not that important. The main things to understand are it's twice as likely in women. Peak onset is in the middle age, so 20 to 40. And it actually does have a higher risk with a positive family history, surprisingly. So it actually does have a genetic basis in some cases, as well as there being some social associations. So marital status. So if you're married or separated or divorced, postpartum depression is also a commonly cited phenomenon, as well as negative life events, of course, can lead to depression. Uh, the bottom diagram also shows you the different types, as I mentioned, but also the pathway of what those look like over time. So the most common one, well, I guess I'll start with the average person, which is the green line. You have episodes of being happy, I guess, or overactive, which is the mania. And then you've got depression, which is the not so excited part of your life, right? And it doesn't really follow a pattern. Essentially, what happens is sometimes you're happy and things happen that make you feel sad, right? That's what the average person experiences. But when it comes to clinical depression, that's a completely different picture because now it starts to follow an actual pattern and it's outside of the person's control sometimes. So unipolar depression, which is that blue line, you kind of cycle in and out of particular moods, right? So you have manias, depressions. With unipolar depression, it's mostly going to be towards the depression side, as the name suggests. So mostly unipolar. Whereas you also have rarely bipolar disorder. So bipolar 1, bipolar 2, essentially where you go through roughly equal phases of mania and depression. And then you have cyclothymia, which is very, very not as common, I guess. It's not something we need to know. The main thing to understand is that you have cycling. Some people are more along the lines of the depression aspect. Other people can actually then also go into periods of mania as potentially like a compensation. The main thing to understand here is how do we diagnose depression? Interestingly, depression is not always diagnosed, and sometimes it's overdiagnosed, sometimes underdiagnosed. So it's very tricky to be able to figure out exactly how we diagnose it. And I'm sure by the time this lecture is recorded, the DSM-5 criteria might have been either revised or overthrown. I'm sure it's still there, but there might be newer, more fancy, and probably more accurate ways to diagnose depression in a patient. But the DSM-5 criteria is the classic one that is used. It requires at least 5 symptoms within the same 2-week period to be positive. You need at least one of depressed mood or apathy, which is correlating to loss of interest. And then at least 4 of the below things that are actually signs of physiological changes. So not just the fact that you're feeling like your mood is lower than usual, but it actually leads to quantifiable changes in the way that your body works. So significant weight loss or gain without any dieting, so unintended. sleep disturbance like insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, loss of energy nearly every day, feelings of worthlessness or inappropriate guilt, decreased concentration and executive function, or recurrent thoughts of death or suicidal ideation. So according to DSM-5, you need one of the depressed mood or apathy and then four of the below. Generally, treatment is, as with all non-emergency conditions, you usually start off with non-pharmacological management. So suggesting physical exercise, healthy diet, CBT, not case-based tutorials, cognitive behavioral therapy, interpersonal therapy as well. So the social aspects of it. But of course, if it's becoming ineffective, then as an adjunct, you can add on medications. And you don't want to stop the non-pharmacological. You just want it to be in conjunction to be able to find a more appropriate way to manage this person's depression. Of course, to avoid the complication or the worst possible scenario, which is the suicidal ideation. So again, the basis behind how a lot of these medications work comes from the monoamine hypothesis. So essentially what a lot of scientists believed was that depression arises because you have a deficiency in these compounds known as monoamines within the brain. So monoamines are neurotransmitters that include things like noradrenaline, serotonin, dopamine. Therefore, what they believed was if we increase the levels of monoamine through some medications, then theoretically we would have an improvement in symptoms immediately. Right. So what we'd expect is that if we administer, and again, we'll go through these medications in a lot more detail. But let's say we administer a monoamine oxidase inhibitor, which essentially blocks the enzyme that breaks down monoamine. If we administer it, and once the plasma levels start to increase, right? So you got this red line. Once plasma levels start to increase, you would expect that their mood would also follow the same pattern, like roughly the same time. But what you see is that you actually have this delayed effect. So it takes quite a bit of time for your mood to reach a point where it's comparable to the plasma levels of MAO. Monoamines, not monoamine oxidase. So it takes quite a bit of time and there's a delay. So obviously this is probably not the right way to think about depression. And what they've come up with is a better model known as the monoamine receptor hypothesis, which is actually saying that depression is associated with an upregulation of monoamine receptors, which then leads to, as a consequence, lower than normal levels of monoamine. So it's not the low levels of monoamine causing depression, it's actually the high levels of receptors that are present. And now this seems to make a little bit more sense because when we give antidepressants, they elevate your monoamines. And once your body sees that there's a huge amount of monoamines around, then it tries to decrease the levels of monoamine receptors. Okay. And because it takes a bit of time for your body to recognize that, there's too much monoamines, I need to reduce the level of receptors that I'm expressing. That takes some time, and that explains why you have that delay. So receptor levels or receptor sensitivity goes down and the body slowly adapts. And that's why mood takes a bit of time to also follow that particular trend. The particularly implicated receptors seem to be your serotonin, so 5-HT2 receptors, alpha and beta adrenoreceptors as well. Now, there's a bit of side pathophysiology. I don't think this ever really comes up, but it's mentioned in the lecture, so I thought I'd just really quickly cover it. Depression, you can also describe it as reduced positive effects and increased negative effects. So positive effects are essentially good things that you want, but they're reduced in a patient with depression. So things like mood, happiness, pleasure, energy, alertness, self-confidence, those are all reduced. And generally, they think it's because there's too many noradrenaline or dopamine receptors present, in particular the noradrenaline beta-1 adrenoreceptor family. Again, not that important to remember that fine detail. And the negative effects are things that you don't want to have, like depressed mood, guilt, anxiety, fear, hostility, irritability, loneliness, that get increased in a patient with depression. So mainly through serotonin and noradrenaline receptors. And the most implicated ones are the 5-HT2A and 5-HT2C receptors, so the serotonin subtype 2A, subtype 2C receptors. And it seems that there's specific areas of the brain that are thought to be affected in depression, not just the whole brain. So chronic stress and low monoamine levels can cause apoptosis of neural tissue, which leads to progressive dysfunctions. It also seems to particularly reduce the prefrontal cortex and hippocampal volume, which can explain Sorry, I've got a lecture on the side and I'm just trying to leave. Okay, that's all right. Sorry about that. Seem to particularly reduce the prefrontal cortex and hippocampal volume. Explains why there's effects in cognitive behaviors because it's affecting the prefrontal cortex and also learning and memory issues. Hence, we think that classical antidepressants not only attempt to alter the biochemical levels of some of these neurotransmitters, but they might also then, therefore, promote those lost neurons and neural tissue from being generated back again, and therefore restore some of that function that is lost. So it's very interesting and it's a developing field. Okay, let's get to the actual management. So the parts that are actually going to be examined. The main two medications that I'm going to talk about are the tricyclic antidepressants and the SSRIs. So the tricyclic antidepressants are or were the traditional first line medications. So it includes medications like desipramine, amitriptyline, and imipramine. So you can see there's a common sort of pramine at the end, apart from amitriptyline. Sounds the same, similar though. The mechanism is that it blocks the reuptake of noradrenaline and 5-HT, but it tends to favor the former. So it tends to favor noradrenaline a little bit more, but essentially it blocks both of them. And therefore you have greater concentration of both of these, which leads to receptors being downregulated and therefore helps with the depression. There's a lot of adverse effects though, because while it does affect the noradrenaline and 5-HT receptors more, it actually also blockades at least two other types of receptors. So the muscarinic blockade, which is parasympathetic, right? So you get things like dry mouth, blurred vision, urinary retention, constipation. It can also block the histamine receptors, H1 receptors, which can lead to mild sedation. And it can also block alpha-1 receptors, which can lead to orthostatic hypotension. And if you have a combination of anti-muscarinic effects and noradrenaline effects, then you can actually lead to hyperexcitation of the heart. So at the therapeutic dose, you might get some ECG abnormalities that can actually be associated with suicide risk, surprisingly. And if you have an overdose, then it can lead to arrhythmia, so atrial ventricular extrasystoles, and even sudden death because of ventricular fibrillation. So obviously, a lot of things you need to be careful about, even at the therapeutic dose. But just remember that you can have some effects that are unintended because these antidepressants are not very specific to just noradrenaline and serotonin. In contrast, you have these selective serotonin reuptake inhibitors, so SSRIs, which are now the traditional first line. And they include medications like fluoxetine, as well as citalopram and paroxetine. So the main ones to remember here is fluoxetine. Mechanism is that it blocks the reuptake of only serotonin or 5-HT, which therefore achieves the same thing, so downregulates receptors. The adverse effects can include an acute phase of anxiety. And the reason why is because before the downregulation happens, your body tries to compensate by really increasing the levels of serotonin. And so you get sort of like this patient is almost in like a mania phase where they're really, really anxious. But then over time, it's actually very, very effective in reducing the symptoms associated with depression. The thing to be really careful about here in terms of adverse effects is this concept of a serotonin syndrome. So it occurs because you have an excessive level of 5-HT. So not only the acute anxiety, but you can also have other things based off the different receptors that are affected. By no means do you have to remember these subtypes, but just remember it's agitation, anxiety, panic attacks, akathisias, nocturnal myoclonus, sexual dysfunction even, nausea, vomiting, and GI disturbances. And it's usually when you co-administer with medications that also increase serotonin levels. So monoamine oxidase inhibitors, which we'll cover in a sec, other SSRIs, the TCAs we just discussed, tricyclic antidepressants, St. John's wort, triptan medications, which can be used for migraines, ecstasy, and tramadol as a pain medication. So you get agitation, myoclonus, hyperreflexia, incoordination, and sweating or tremors. So if you see this in a patient, you know something's wrong. You will have to try and find some ways to reverse the excess levels of serotonin. On the other hand, you have these other medications called irreversible monoamine oxidase inhibitors, or in short form, MAOI, which includes medications like phenylcypromine. Really hard to pronounce some of these medications. The mechanism is it essentially non-selectively binds to and therefore destroys monoamine oxidase subtype A receptors. So I've bolded it because it's really important to remember that it's A. In another lecture, specifically in Parkinson's, you will talk about monoamine oxidase B receptors, which are responsible for something a little bit different. But here it's monoamine oxidase A, which means those enzymes can no longer break down monoamine, so you get increased levels of those particular hormones, those particular neurotransmitters, and therefore downregulation of receptors. However, within about 2 to 3 weeks, your enzymes that are destroyed, they're not just going to be permanently destroyed, right? Like they're gone, but your body will then just increase the level of enzymes it produces. So within about 2 to 3 weeks, you might have those symptoms coming back, and then you might have to up the dose or give more medication. So it's not a permanent fix, even though it's irreversibly destroying the enzyme. Adverse effects, commonly, at a mild level, insomnia, some level of drowsiness, but also because it, again, is not as specific, you can have things like postural hypotension, because for some reason, these false neurotransmitters build up within the CNS CV control centers, so cardiovascular control centers, atropine-like effects because of potential central effect causing vagal stimulation, and then sexual dysfunction because of loss of libido and causes some risk of impotence. Now, so you can sort of see here that the postural hypotension, atropine-like effects, they're not because it's directly attaching to those particular receptors. It's just because there's some actions within the central nervous system that's not fully understood that is leading to these adverse effects. So non-specific, but similar to this sort of effects we saw in previous medications. Now, the main thing with MAOIs in the context of side effects is the cheese reaction. So that's a very funny name, but essentially, if you see someone who has a hypertensive crisis, very severe hypertensive crisis, who is on MAOIs, you should have a high clinical suspicion of a cheese reaction having happened. Why does it happen? It's actually very straightforward. So monoamine oxidase inhibitors, they block your monoamine oxidase enzymes, but it's indiscriminate. So it doesn't just block things that are responsible for brain function, but also in the gut and the liver. And these gut and liver enzymes, they're actually responsible for digesting this monoamine called tyramine, which is found in, surprisingly, aged cheese, which has a high content. Also, I think in red wine or something like that. But there are many foods that contain tyramine essentially. And if you have too much tyramine in your body, it causes a massive exocytosis of noradrenaline and 5-HT from the nerves, which leads to the hypertensive crisis. So if you're on these medications, you should tell patients to try and avoid consuming foods with a high tyramine content, like aged cheese. Wow, okay, I didn't realize it was going to go completely black, but I've kind of done this because you have the irreversible MAOIs, but you should also try and think about, okay, if you want to avoid the cheese reaction, one way you can do that is by kind of modifying these monoamine oxidase inhibitors. And in this case, they're called reversible monoamine oxidase inhibitors, or REMAs, which can include medications like moclobemide. So it reversibly inhibits the action of monoamine oxidase A enzymes found within the nerve terminals. So essentially achieves the same thing, but it's reversible. And it's much more selective for monoamine oxidase A, which means that there's no cheese reaction. It still can cause a little bit of nausea and vomiting, but because there's no cheese reaction and there's none of the other non-specific effects, you don't get postural hypotension and you don't get atropine-like side effects. So overall, it's a better medication to go for, but there are still some cases where you might prefer monoamine oxidase irreversible inhibitors. Okay. Serotonin, there's kind of extra medications just to have a think about. They're kind of more specific, I guess, so medications that people have designed so that they're as specific to neurotransmitters as you can be. So you've got serotonin antagonist and reuptake inhibitors, so SARIs, which includes medications like nefazodone. So essentially, they have two modes of action. They not only reduce the uptake of 5-HT through the inhibitors, but they also antagonize those particular receptors. They have a little bit less potency though. They're selective for 5-HT2A antagonism, which prevents those effects that we saw in SSRIs that cause anxiety. So compared to SSRIs, which have initially really bad anxiety and then other stuff, you get less of that here, but it's a little bit less potent in terms of effects than with SSRIs or TCAs. They're often used for things like sleep disturbance, like insomnia, and they, as a lesser effect, they can help with sexual function. Adverse effects include sleepiness, dizziness, dry mouth, and nefazodone in particular can cause liver damage, which, if fulminant, can lead to requirement of a liver transplant. Other specific medications, so noradrenaline reuptake inhibitors, only for noradrenaline. So reboxetine can have some muscarinic effects, as you might expect. Serotonin and noradrenaline reuptake inhibitors like venlafaxine, which has some dopamine reuptake effects as well. But these are more specific, and really you just need to know exactly what neurotransmitters are being targeted. So if someone says venlafaxine, which is quite common, you should know that it is responsible for blocking the reuptake of serotonin and noradrenaline. And then you've got alpha 2 adrenoreceptors. Remember, alpha 2 adrenoreceptors are found on presynaptic terminals as opposed to other adrenoreceptors, which are postsynaptic. And the reason why is because once, like say you've released neurotransmitters, they come back and bind to the alpha 2 adrenoreceptors. It's like a negative feedback. So it tells the presynaptic neuron to stop releasing as much neurotransmitter. So if I block these with medications like mianserin and mirtazapine, then I'm reducing my neurotransmitter release, which blocks so the release of noradrenaline and serotonin, therefore increasing the level of things within the actual synaptic region, the synaptic space. Because what's happening is your cell presynaptically is not trying to get rid of all of that excessive hormone anymore. It's just like, okay, I don't recognize the fact that those hormone levels are increasing beyond the normal amount. I'm just going to keep pumping them out. And then finally, just a quick word on bipolar disorder, because we discussed it very briefly at the beginning. Just a bit of context, bipolar, you can have like unipolar conditions, so that's just depression. And then bipolar is manic depression, so it alternates between mania and depression. On the right-hand side, again, a couple of symptoms and signs you might expect in a patient with bipolar. The main thing in pharmacology, though, is not so much to understand what bipolar looks like, but more how you treat it. So if you have a patient with bipolar, you can use medications like lithium to help stabilize their mood. It's unclear how it works, but apparently it tends to permeate through voltage-gated sodium channels, and it's not pumped out, so it just accumulates within the tissue and has some sort of effect. It's less effective in people who have rapid cyclic bipolar disorder. In other words, they go through mania and depression very quickly. So in these patients, you would have to actually go back to anticonvulsant medications. Some adverse effects, lithium can build up and cause toxicity. So you can get tremor or motor hyperactivity. You can also get severely reduced kidney concentrating abilities, or renal failure. It can also antagonize the response to antidiuretic hormone, which leads to nephrogenic diabetes insipidus. Again, might have covered this at some point in endocrine. So diabetes insipidus, essentially ADH can't act anymore, so you get massive release of water through the renal system. So polydipsia, polyuria, nephritis, glomerulopathy, and edema. So the main thing here to remember is just lithium. And the only reason it would not work is if they have rapid cyclic bipolar disorder. So that's pretty much it for this lecture. I know it's very fast, but I think the main things to understand here are if someone gives you a medication name, so any of these medications, if someone says phenylcyprine, you need to know exactly where the drug class comes from and if there's any associated like major side effects. So cheese reaction in particular, if someone says phenylcyprine, you should associate that with cheese reaction. If someone says, for example, fluoxetine, you should be able to automatically say, okay, I need to be worried about serotonin syndrome, just in case you have a patient in your question who has this medication and comes in with the classic symptoms that tell you something is wrong. So that's it for today's lecture. I hope that all makes sense. If you have any questions, feel free to refer to the notes or message me if you would like to discuss something in particular, not just related to this lecture, but anything that you're having issues with. Best of luck for your studies, and I will see you in another lecture. See ya.